Dear colleagues, hello and welcome to another episode of the TheSynapse e-learning series. Today with us we have Dr. Warren Scicluna, a consultant radiologist with special interest in uroradiology, with whom we will be discussing the advances and the role of imaging in prostate cancer. Dr. Scicluna, thank you very much for accepting our invitation. I would like to start my very first question by asking you about PSA testing. As we know, there is quite some controversy at using PSA testing as a screening procedure. What are your comments on this, and what kind of PSA results should pose red flags for medical professionals and justify referral for imaging?
Thank you, Maria, for the invitation. I think it's a very relevant question. PSA, in my opinion, is a very good screening tool which gives an indication, rather absolute diagnosis. Unfortunately, this is not available on our National Health Services system. However, it is a rather inexpensive test which I think every male over 50 should have at least once every year. I think it all depends on what level of PSA the initial test is. What do I mean? So if a patient has a PSA of 1, then we are rather safe to say that that is a normal PSA and there is nothing to worry about. If the PSA level at the start is at 14, 15, 20, then we have red flags and he needs to be referred immediately. The other very important thing that we need to consider is the doubling time. The doubling time is how long it takes for an initial PSA to double in amount. So if we have a patient with a PSA of 1 this year and the PSA of 2 next year, then the doubling time is 1 year, and this is a bit alarming. If you have a patient with a PSA of 5 and the next year is 10, then that is the same thing, also alarming. Very importantly, PSA must be taken also in consideration with digital rectal examination. So if someone has a normal PSA level but an abnormal digital rectal examination, that is also a red flag and the patient needs to be referred. Family history of prostate cancer is also extremely important. So if you do see a rising PSA, even if it's a slow rising PSA, if the patient has a family history, please also refer.
Thank you very much for that very good introduction. As we know, there are a number of imaging modalities which can be used in prostate cancer detection, some of which are more easily available than others. Can you discuss the different methods available, their role in prostate cancer imaging, and what guides the decision on what technique to use in different situations?
I think that there are predominantly two modalities which we use to help us in the diagnosis and in biopsying the prostate. So we're talking about MRI of the prostate and transrectal ultrasound. So by far the only imaging modality available for diagnosis of prostate cancer is MRI of the prostate. A transrectal ultrasound is not an indication for diagnosis of prostate cancer, simple. Transabdominal ultrasound of the prostate is only used to measure the size of the prostate gland. Prostate cancer has got absolutely nothing to do with this. MRI is readily available nowadays. It is the modality which we use to detect and to stage prostate cancer. And I feel that MRI should be referred to by the urologist. I think it's a rather specialist examination, especially if it's done on the National Health program. Sometimes it is necessary to combine two modalities together. Transrectal ultrasound of the prostate is used for biopsy of the prostate. However, nowadays we also have the capability of merging the two modalities together. So we have an MRI of the prostate, which is showing us a cancer. We can upload the imaging on our ultrasound machine and we can combine the two modalities together so that it makes easier for us to diagnose, to see where the tumor is and to take the appropriate biopsy.
Now that we have discussed the main different techniques available, Can you indicate the main advantages and disadvantages of the different techniques and how effective they are in the detection of prostate cancer, and what is the level of diagnostic accuracy that they provide?
That's a very good, important question as well. If I had to mention the disadvantages of transrectal ultrasound, for example, is very simple. You can't use it for diagnosis of prostate cancer. Its advantage is that it is cheap and it is also readily available. The very big disadvantage of MRI of the prostate is that it's very expensive and it is very time consuming. So now that we are having more and more MRI of the prostate being performed at our national health system, then what you get is you start getting a waiting list and so on, which is also a disadvantage. The very good advantage of MRI of the prostate is it is extremely accurate. Okay, so what our main concern is we want to diagnose a big or an aggressive tumor on MRI. The main thing that we want to find on an MRI are those high volume and high Gleason tumors. We are not really interested in those very small, low Gleason tumors. Those are extremely common, and sometimes MRI is not good in finding them. We do not really need to know about them. Regarding diagnosis, localization and staging, MRI is extremely helpful. Nowadays, we have two different protocols for the MRI. We have a staging protocol and a detection protocol, we call it. So what's the difference between the two? A localization protocol is when we have a patient who we don't know whether he has prostate cancer or not, and we want to see whether he does. And a staging protocol is when we already know that he has a tumor in the prostate and we want to stage the patient locally. Staging obviously helps us in choosing our different choices, how to treat the patient, whether it's active surveillance, whether we're going for prostatectomy, whether we are going for hormonal treatment, brachytherapy or high dose radiotherapy or external beam radiotherapy. What is also important with MRI is that once you stage the patient, once you treat the patient, you might also want to follow up the patient. So if we have a patient who is on active surveillance, you have patient with rising PSA on active surveillance, then you want to restage the patient and see whether the tumor has grown, whether there's a new tumor, whether it has infiltrated anywhere. And you might change your opinion on not staying on active surveillance and going for treatment, active treatment. You can have patients who have been actively treated and their PSA starts to rise again. Those patients you need to restage again. We can also assess response to therapy after external beam radiotherapy especially. And regarding management of prostate cancer, MRI is also extremely important for surveillance, treatment decisions and response to therapy. A lot of prostate cancers are placed on active surveillance, which means if it is a low-risk cancer, PSA of less than 10 and the Gleason score of 6, the patient might opt to have nothing, absolutely nothing done, and to have recurrent PSA level estimations and, if necessary, recurrent MRIs. If the PSA rises, you can repeat the MRI and you can restage. If the tumor increases in size or there's a new tumor, then you might opt to go for active treatment. The treatment decisions are extremely important. Why? Because according to the staging, then we can decide what kind of active treatment the patient can have. So if you have a large prostate, you cannot send the patient for brachytherapy. It helps us decide on whether we stay on active surveillance, whether we go for external beam radiotherapy, whether for prostatectomy, whether prostatectomy is feasible. So it gives us all these important decisions. The response to therapy is also extremely important because when we have a patient who's been actively treated and his PSA starts to rise again, then we can restage. If the tumor has recurred, if the tumor has grown, then we can go for salvage treatment. If there are metastases, then we can direct the oncologist on new areas to irradiate or for chemotherapy.
Thank you very much, Dr. Scicluna. You have walked us through the role of imaging through the various stages of cancer, not simply in diagnosis. My next question refers to ultrasound-guided biopsies. Is the possibility of getting false negative results an issue? And if so, what can be done to minimize this risk?
Yes. The simple answer is yes. You can get negative results when there is really and truly a prostate cancer present in the prostate gland. The main problem is the way that we do the ultrasound-guided biopsy. Nowadays, the most common way of doing it is what we call a sextant biopsy, in which we take 6 prostate cores from one side of the gland and 6 prostate cores from the other side. They are rather taken at random from the base, from the mid-gland, and from the apex of the prostate gland. If the patient has an MRI prostate performed before, then it is extremely relevant to the urologist or whoever is doing the biopsy, because it directs the urologist in which area he needs to take the biopsy. However, if, for example, there is a patient who has an anterior tumor, most of the times, unfortunately, these are missed. And then we do what we call a targeted prostate biopsy, which means that we do not just take at random the different prostate areas. We direct our biopsy in the area of concern. Sometimes we have very small tumors, which we cannot see on ultrasound. And what we do is we do what I mentioned in the beginning, that we do a combined MRI and ultrasound-guided fusion biopsy.
Dr. Scicluna, one final question. It is known that in some cases, chronic inflammation of the prostate gland can mimic tumors. What can you comment about this? And are there any special techniques which can be used to distinguish between chronic inflammation of the prostate and prostate tumors?
Unfortunately not. It is one of the few things that MRI prostate is not really good at. There are certain things that we look at on a prostate MRI which can distinguish between inflammation and a non-aggressive tumor. What we usually do, especially in our reports as radiologists, we usually can direct the urologist what we think, and most of the times we are correct. But a lot of the times you need to include both in the differential. Unfortunately, a lot of people, a lot of males will get biopsies for nothing, because where we think that there might be a small non-aggressive tumor, he might have just chronic inflammation over there. However, at least it's a reassuring investigation, and if it's negative, it's negative.
Dr. Scicluna, thank you very much. What I ask from you now is a final take-home message to our audience today.
The take-home message is especially for males. Please, PSA every year after 50. I do not think that PSA is relevant before the age of 50. However, as in the community, we need to encourage males to take PSA, and especially those males who have a family history of prostate cancer, to refer to urologists for PSA estimations and for digital rectal examination.
Dr. Scicluna, thank you very much for a very interesting lecture. I hope that this e-learning episode have helped you to increase your knowledge on the role of imaging in prostate cancer. For more e-learning videos, I invite you to visit www.thesynapse.net/CME.